Good morning to all of you. So today we are going to start the second part of anorectal malformation. In the initial part we have already learned what we mean by anorectal malformations. We also have studied what are the signs and symptoms. We also have studied what is the pathophysiology, including the diagnostic tests. So remaining portion we are going to start today. We will start the management part. So we have already studied that some children with anorectal malformations, they will give a history that the child has not passed meconium maybe for 2 or more days. Okay, so if you see any sign and symptoms of anorectal malformation, this child may be requiring surgery. So keeping that in mind, we have to keep the child nil orally, and the child has to receive IV fluids. Okay, treatment will depend on what are the child's symptoms, what is the age, what is the general health, what is the severity of the condition. Some babies may require surgery immediately. So different surgeries are there. We are going to study each of it, and the type of surgery which the child requires will depend on the type of the problem. Okay, so we'll deal it one by one. First is narrow anal passage. Okay, so we studied about stenosis. Okay, so if it is a case of stenosis, narrow anal passage. Okay, so you may not require a surgery at all. The only thing which is required is anal dilatation. Okay, so anal dilators are available. So what you need to do is we have to use anal dilators so that this will help to stretch the anal muscles so that the stool can pass through. Okay, so if it is a narrow anal passage, no surgery, only frequent anal dilatation is required to stretch the muscles to facilitate the पैसेज ऑफ स्टूल. ठीक है, ये क्लियर है आपको कि सर्जरी ज़रूरत नहीं है इफ़ इट इज़ ओनली एनल स्टेनोसिस. ओके, यू कैन मैनेज विद एनल डायलेटेशन. ओके, सेकंड इज एनल मेम्ब्रेन. हम लोग ने पढ़ा था लास्ट टाइम. ओके, इन द प्रीवियस क्लास समटाइम्स एवरीथिंग इज ओके, ओनली थिंग द एनस इज कवर्ड बाय मेम्ब्रेन और अ टिश्यू. ठीक है, अगर ऐसा है देन यू रिक्वायर अ सर्जरी. ओके, टू रिमूव द मेम्ब्रेन, एंड देन anal dilatations may be done with the help of to help if it is you may have two things, either it is membrane only, then removal of membrane will solve the problem. Sometimes it is a combination of maybe stenosis with covering of the membrane. So then the first step will be surgery to remove the membrane, and then is you require anal dilatations with the anal dilator to manage the narrowing of the anal passage. Okay, next is now we are going to study the major part, that is lack of rectal or anal connection with or without fistula. Now because this is the second class, now you understand what is a fistula. We have studied in the previous class that rectum may not have any attachment with anus, or sometimes it may be a blind pouch, or sometimes rectum may be attached to some other structure. Okay, these all things we have already studied. So if it is if the rectum and anus is not having any anal connection, this may be with fistula or maybe without fistula. So in the previous slides, previous class, I had already shown you the diagram of these two aspects, with or without fistula. Okay, so depending on the type of problem, we may have different type of surgery. First is colostomy. Colostomy, if you remember my class on Hirschsprung's disease, we had discussed about colostomy. So same colostomy is done here also. I will be showing a photograph of the colostomy procedure in the next slide. Okay, so what is done? So a colostomy is performed in children who are not amenable to primary pull through, either because of malformation complexity. Okay, we have studied what is pull through in the Hirschsprung's disease. What you do is, whatever is the affected part, that is cut, and the remaining parts are pulled and attached to the normal part. So if that is not possible, if pull through is not possible, then the only alternative available is the only alternative surgery is available is colostomy. So what you do is you take the colon, and the end of the colon will be over the surface of the skin, and the baby will be passing feces from that stoma. The opening of the colostomy and the skin is called as stoma. Okay, so the ends of the intestines are brought through the openings of the stomach, and the baby will be passing the stool into a collection bag. Okay, another opening is there which is called as mucus end. Okay, so the lower end will let the mucus made by the intestine will pass to the collection bag. So here in this type you have two collection bag. It's not only colostomy bag, but it is a mucus bag also. So in the remaining part of the colon, there may be collection of mucus, there may be collection of gas and sometimes fluids. So that has to be collected. Otherwise, if you don't collect it, then again it will lead to abdominal distension. So here in this type you have two openings. Okay, so colostomy, and the advantage with colostomy is the digestion is not affected. Only thing, instead of the baby passing through stools or feces through the anus, the feces will be coming out in the collection bag. Okay, so this is, and one end will be for the mucus. See, this diagram will make the concept clear. See, this part is not having any problem. Now here you have a colostomy. Okay, here you have a mucus fistula. So this will end up in stoma and will have a collection bag through which feces will be coming. In this part, feces will not be there. So this is only for mucus. Okay, mucus may be gaseous, may be some fluids if it is there. Okay, so this is basically for mucus and gas. So, and here you have a missing anal opening. Okay, so this is a colostomy with mucus fistula. Now this is a actual baby. Can you see this reddish discoloration? So that is a basic issue with colostomy. So this is called as stoma, through which the baby will be passing stool, and this will be covered with a collection bag. And the issue here is, see here the skin integrity is hampered in the nearby area. So if you don't manage it properly, it will lead to skin excoriation also. Next is the attaching the rectum to the anus. We have studied that sometimes the rectum may not be attached to the anus. Okay, so then the rectum has to be attached to the anus. So colostomy will stay in place for a few months after the surgery. Okay, so once colostomy will stay in place, then what you do is, after some months you attach the rectum to the anus. Okay, so this area can heal without being infected by stool. Why? Because colostomy is there, the baby will continue to pass the stool from the stoma. Okay, so remaining part and rectum is down. Okay, so rectum and anus will be joined together, but healing will be good. Why? Because the area will not be infected by the stool of the baby. Okay, so now rectum and anus are now joined, but the stool will be leaving the body through the colostomy. Still they are closed with surgery. Okay, then once rectum and anus are attached properly, it is healed properly, then you go for another operation that is called closing of colostomy. So this is done 2 to 3 months later. Okay, so you attach, see if you remember the step, first you do a colostomy, second is you have a mucus fistula also. Okay, so you do it, first step is over. Second step is you attach the rectum to the anus. The colostomy is still open, and this is advantageous because this helps the area to heal properly. Third is, what you do is, after 2 to 3 months you close the colostomy. Once you close the colostomy, it takes time for the child to pass normally through the stool, through the rectum. Okay, and anus. Okay, first these stools often they will pass the stool often, and second they will be loose. Okay, so diaper rash and skin irritation will be a problem. Okay, after a few weeks what happens is, gradually the stool they will pass stool less often and they will become more solid. Okay, so sometimes this may even lead to constipation also. Then you need to give diet which will reduce constipation. For example, fruits, vegetables, juices, whole wheat grains, cereals, beans. Okay, that is fiber diet. That is, you need a high fiber diet so that the constipation can be managed. ठीक है, clear है. फॉर क्लोजिंग कोलोस्टमी आपको 2 to 3 months वेट करना है, सो दैट द रेक्टम एंड एनस विच इज़ अटैच्ड वो हील अच्छे से हो गया है. देन यू क्लोज द कोलोस्टमी. कोलोस्टमी क्लोज हुआ, नाउ द बेबी हैज़ टू पास द स्टूल फ्रॉम द रेक्टम थ्रू द एनस थ्रू द एनल स्फिंक्टर, इट हैज़ टू कम आउट. पर क्या होता है, इट टेक्स टाइम फॉर द चाइल्ड टू एडजस्ट विद दिस. ओके, सो शुरू में दिस several after several days the child will start passing stool. शुरू में the stool will be loose. Okay, gradually this will become hard and sometimes it can even lead to constipation. If this is so, then this has to be managed with the high fiber diet. Okay, next is we have a procedure which is called as PSARP. Okay, posterior sagittal anorectoplasty. Posterior sagittal anorectoplasty, PSARP. Okay, so children who have an anorectal malformation, they have this defect. Okay, they have this surgery, and posterior sagittal anorectoplasty, after the surgery is planned, this has given good results in the management of anorectal malformations. Okay, so this procedure is called as anorectoplasty. So it involves moving the anus to a location within the muscles, that is the anal sphincter that controls the bowels. Okay, so this surgery allows the gas and solid waste to leave the body, and this may occur soon after the birth, or timing will depend according to the child needs. So what you do is you shift the anus to where the anal sphincter is present. Okay, you move the anus to the location within the muscles, that is anal sphincter, which controls the bowels. So once this surgery was done, so this helps the solid waste as well as the gas to leave from the body, and this surgery can be done soon after the birth also. So this all depends on what are the associated defects. Okay, so I think this concept is clear. Posterior sagittal anorectoplasty, in this surgery what we do is we move the anus to the anal sphincter, and anal sphincter, we know this, they control the movement of the bowel. Okay, so this surgery allows the gas as well as the solid waste to leave from the body. Okay, and this surgery can be done soon after the birth also. Now is what diet is to be given. Okay, so more or less no special diet is required. Okay, so what happens is the basic issue is constipation. Okay, to avoid constipation we have to avoid bread diet. What is bread? Bananas, rice, applesauce and toast. So this has to be avoided, and high fiber and laxative food, that is whole full grains, bread, dairy, fruits, vegetables, greasy, spicy food should be encouraged. Okay, next is activity. So these children are otherwise healthy. The only limitation is around the surgical procedure. Okay, till the healing takes place, otherwise the child can grow and develop as other children. Now is in pharmacological management, antibiotics needs to be given. See, if you remember my previous class, we studied that if there is if the rectum is attached to the urethra. Okay, so what happens is, through the urethra, what you find is, if you have a fistula like that, then the urethra will have passage of both urine and stool. If such is the condition, then the chances of infection is very high. Okay, so urinary prophylaxis is used to mitigate means lessen the risk of urinary tract infection and urine sepsis. For example, maybe urinary fistula or vesicoureteral reflex. Okay, so these are the basic problems which can be there. So antibiotic prophylactically can be given. Then laxatives, constipation is a basic issue, so laxatives needs to be given. Okay, so laxatives can be senna, can be milk of magnesia, can be propylene glycol like Miralax and Glycolax, etc. Okay, so here in India what we follow common is milk of magnesia. Okay, in nursing management we have pre-operative nursing care. So as soon as the anomaly is noticed, oral breastfeeding has to be withheld, IV fluids has to be started, abdominal girth has to be measured. I showed you a photograph of this swollen belly, अगर आपको याद होगा. Okay, so that is why हमको abdominal girth we know how to measure at the level of the umbilicus. Okay, so we have to measure this. Then is gastric compression. कैसे हम लोग करते हैं? We use this, suppose if it is a baby, infant feeding tube pass करेंगे and then we attach, जो end है उसको हम लोग open रखेंगे and we will attach to a polythene. ठीक है, so this will help to drain. इसको हम क्या बोलते हैं? Gastric compression. Okay, feeding के लिए हम लोग क्या करते हैं? बंद कर देते हैं. We don't close it here, but we allow it to remain open. So whatever gastric secretions are there, they will be collected in a bag outside. Okay, so इसको हम क्या कहते हैं? Gastric compression. Then vitals also has to be given. Then prepare the family psychologically for the infant surgery. Okay, so you can imagine the stress of the child. The child is very abnormal. The child has not passed stool. Now if the surgery is being planned for colostomy, then more surgeries are required to finally manage all these things. Okay, so the parents will require a lot of psychological support in relation to infant surgery. Okay, next is post-operative. IV fluids will be continued, nasogastric suction will be continued, and oral feeding will be started when the peristalsis is returning. Okay, so for that we hear the bowel sounds, and depending on that we manage the oral feeds. Now this nursing assessment. Okay, so prenatal ultrasonography examination findings are often normal, although there may be history of polyhydramnias. Polyhydramnias means a large collection of this amniotic fluid, or there may be intra-abdominal cyst. So this may suggest imperforate areas with associated hydronephrosis. Hydronephrosis can be diagnosed prenatally also. Okay, so hydronephrosis can be identified in such babies. Okay, in the prenatal history. So that is why in history we have to check the findings of prenatal ultrasonographic examinations. This might be normal, or this might give us an idea of associated defects. Okay, second is once a child is born, the child will have physical examination. Physical examination, we see, had shown you in the previous slides picture that the anal aperture is not there. Okay, dimple is there, but anal aperture is not there. Okay, so this next is you have to take a history whether the child has passed urine or stool. Okay, whether the child has passed stool within first day, or is it second day, or the child has not passed stool, and then you have to see the abdominal distension. Okay, so this the routine physical examination of a newborn baby will help us to get an idea. Okay, nursing diagnosis is fluid volume deficit related to excessive loss through vomiting. The child can have even vomiting. Okay, if because of the abdominal distension, the child may even vomit. Okay, then impaired skin integrity related to colostomy. I have shown you the diagram. Around the stoma, the skin was looking very red, and there is skin risk of infection related to surgical procedures. Okay, next is the major nursing care planning and goals. Okay, the major nursing care plans and goals for the patients are: first is maintaining adequate hydration with moist mucous membrane, skin turgor, and capillary refill good. Okay, so this is what we want. Okay, this is our goal, that hydration has to be good, skin turgidity has to be good, maintained, and mucous membrane should be moist, and the capillary refill time should be good. Okay, capillary refill time कैसे हम लोग करते हैं? We blanch the skin. हम लोग thumb से भी देख सकते हैं, and we can also see it over the sternum. You press over the sternum, blanching हुआ, then you remove it, फिर देखते हैं कि कितना देर लगा. Okay, so 3 seconds is the less than 3 seconds is the normal time. If it is taking more than 3 seconds, so this indicates the condition of shock. Okay, then you have to maintain stable vital signs, adequate output of urine, achieving dry and damage free skin around the colostomy. This is one of the major goal. Okay, the skin has to dry, and damage free skin should be there, and there should be absence of infection. Now how to what are the nursing intervention? We have to avoid infection. Okay, so we have to teach the caregivers how to keep the skin clean with soap and water, and also to diaper the baby as we do it. Then is we have to monitor the WBC count. We know that WBC increases in cases of infection, so that's why from time to time WBC count has to be done. Then infection control practices all has to be practiced, okay? And the hand has to be washed before contact and between the procedures with the patient, okay? Protect skin integrity. Protective ointment is available, so that can be applied around the colostomy. And then monitor site of impaired skin integrity at least once a day for color changes. We have to see for redness, swelling hair, pain hair, warmth hair, all these things, okay? And we have to keep a sterile dressing over the wound. Then restore balanced fluid volume. Administer parenteral IV fluid we have to give, because we cannot straight away start the breastfeeding. So this baby requires IV fluids with immediate infusion fluids for patients with abnormal vital signs, okay? You have to check with the correlate with the vitals, and depending on that you have to see. Then teach the family members how to monitor the output at home, okay? Then instruct them to monitor both the intake as well as output. So we need to teach them all these things. Now what is evaluation? Goals are met as evidenced by maintaining adequate hydration with moist mucous membrane, skin turgidant, capillary refill. So whatever was our goals, based on that we will evaluate if the baby is having a good moist mucous membrane, skin turgidity is good, capillary refill time is good, then it is good. Then vital signs are stable, urinary output is there, and the skin around the colostomy is not having any infection, no damage, and there is absence of infection, okay? Now what are the complications? Complications first is narrow anal passage, okay? The biggest problem is the child may have trouble passing. We have studied that anorectal malformations are of different types. Depending on the types, the complications are there, okay? So first is narrow anal passage. The child may be having difficulty to pass the bowel movement. There can be constipation, there can be even a painful defecation, okay? Second is there can be membrane, तो bowel movement हो ही नहीं रहा है. Third is rectum is not connected but there is a fistula, so you will find that infections will be there because urethra is having a mixture of both urine as well as stool. Then rectum is not connected to anus, so there is no fistula, so there is no way for the stool to leave the intestine, okay? So if you don't manage such a case, then it can be even fatal for the baby, okay? Death bhi ho sakta hai if you don't manage it immediately, okay? Now prognosis is depend on the type of fistula, okay? Rectoperineal fistula है, 100% चांस है बावल कंट्रोल का. रेक्टोवेस्टिबुलर है, वेस्टिबुलर हमने पढ़ा था, इट इज इन फीमेल्स, ओके? So there is 95% chance of bowel control. Recto-urethral bulbar fistula, this occurs in male children, so there is 85% chance. In perforate anus without fistula, it is 80 to 90% chance of bowel control. Recto-urethral prostatic fistula, it is 65% chance, and recto-bladder neck, it is only 15% chance of bowel control, okay? So these are the different percentages based on the sacral ratio. These are all percentages which you have studied. Yes, so these are the different measurement, anterior posterior as well as lateral measurement, okay? So we have A, B and C. So what you need to do is to calculate sacral ratio, we have to divide BC divided by AB, okay? So this is BC, so this measurement divided by this measurement, okay? This measurement divided by this measurement, BC divided by AB, okay? So this will give you the sacral ratio, okay? ठीक है, sacral ratio कैसे calculate करेंगे, समझ में आ गया. Next is you have to see your answer. If your value is equal or more than 0.7, ये answer आ रहा है तो good bowel control, okay? If your values are between 0.41 से 0.69 है, that is undetermined, okay? So if it is less than 0.4, then it is poor bowel control, that is fetal incontinence, okay? अभी आपको समझ में आया. Sacral ratio is BC divided by AB, and then you have to see for the values. If it is 0.7 or more, good bowel control. 0.41 to 0.69, it is not clear, undetermined. If it is less than 4, is less than 0.4, it is poor. Okay, so this is the prognosis for such children. Okay, so that was all about anorectal malformations. I hope that you have understood the topic well. Please go through the topic once again. Okay, next week I will be taking a test on this, so please go through it. If you have any doubts, please ask. Thank you so much.